maybe 30 seconds or 40 seconds. We're going to show you the whole interview process here. So take a look at this.
Hello, everyone. I'm News Now from Fox host Pilar Arias, currently joined by Dr. Pierre Corey, who just gave on Tuesday some very emotional and powerful testimony on Capitol Hill. Doctor, how are you doing?
Yeah, a little emotional is correct. I'm doing okay.
What is your specialty? What have you studied? What medicine do you practice? And why were you testifying today?
Yeah, so I am a lung and ICU specialist. So I work in intensive care units. I take care of what's called the sickest of the sick. I've been in academia my entire career, myself and my colleagues. And I have to be clear. I'm speaking today not on behalf of my own personal or professional opinions, but I am part of a group that we formed early on in the pandemic. Okay, we formed ourselves, led by Professor and Dr. Paul Marik. He brought us together to try to figure out COVID and to try to figure out effective treatment protocols. We've been working tirelessly reviewing the world's literature on almost every aspect of this disease. And so I'm speaking on behalf of our group, which is a collection of scientists. We collectively have almost 2,000 peer-reviewed publications. So I want to be very, very clear on that. It's not just one doctor's opinion that I'm speaking today.
Right. So your testimony, you got very emotional. If you wouldn't mind explaining to me why that was.
I'm a lung doctor. Everyone is dying of breathlessness. The ICUs are filling. They're all on ventilators and they die slowly. They're on for weeks. I run an ICU where there's nothing but patients with COVID. I don't see any other disease anymore. All I see is COVID, 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 and they're all dying. I can't help but emotional. My entire life and my humanity is being destroyed by this. Are you kidding me? This is not the flu. And I'm so tired of hearing that. This is not the flu. I'm losing patients of all ages, all ethnicities, and they're all dying. By the time they get to me in the ICU, I can't turn them around. I can't recover them. And is that a fair answer as to why I'm emotional?
Yeah, your exact words during your testimony were, I can't keep doing this. You're talking about a drug, repurposed drugs in particular, and one that could have a miraculous impact on not just treating, but preventing COVID-19?
Our group, again, we have come to the conclusion after reviewing months of data that have all come out in the last few months. This is all new data. We never believed that ivermectin was the answer. We thought it might be early on because there was some theoretical rationale that it might work. But what we uncovered in the last 3 months is nothing but repeated studies and trials showing phenomenal effectiveness in multiple areas, not only in prevention, but early and late treatment. And the most overwhelming data is in the prevention of transmission of COVID-19. If you are on ivermectin, the studies and their randomized controlled trials, large and well done, show if you're taking ivermectin, you will not contract COVID-19. I repeat, if you are taking ivermectin, you will not contract COVID-19.
Do you think this is the better option than the vaccines that everybody keeps saying are coming? And today we have the first woman in the UK get a vaccine.
I think they're complementary. I am so encouraged. My group is encouraged by the development of vaccines. We still want to see that data. It has not been peer reviewed and published as far as we know, but we believe that this would be complementary, more rapidly scalable and more quickly scalable. We have too many people dying right now. There's so many people who are going to die while waiting for those vaccines. So this is something that can be pursued immediately and urgently.
The drug, is it ivermectin? I want to make sure I get it right.
Ivermectin. So you have to be clear on what ivermectin is. It already has won the Nobel Prize in medicine for its discovery because of its global health impact. So it's already rid the world of a number of parasitic diseases. 60% of sub-Saharan Africa take ivermectin regularly to rid themselves of the scourge of parasites. What we discovered and what the studies show, it has phenomenal antiviral activity. It absolutely blocks the replication of the SARS-CoV-2 virus, so you don't get sick. The virus can't infect, can't replicate, and can't kill you if you're on ivermectin.
Is the drug readily available, affordable, and does it come in pill form, or does it have to be?
So it's a pill. It's a pill, and what's crazy is for treatment, as little as 1 dose is effective. We have a few protocols, and if anyone wants to go to our website, which is flccc.net. It's the nonprofit organization that I'm a president of that was formed by Dr. Paul Marek. We have put out our treatment protocols from the beginning. They're all highly effective. We have one for the hospital, and now we have one for prevention and early treatment. We have the doses on there. So it's oral. Now, is it readily available for the country? There are not enough doses available now to treat everyone. However, we've spoken with some of the one pharmaceutical company that supplies, and they can quickly scale up, and we hope they do. And I'm really hesitant to mention this, but ivermectin is also widely used in animals, and there's veterinary grade ivermectin there. Now, it's not recommended to use because it hasn't been tested in humans, but it's the same drug. It just does not have the same level, same low level of impurities that the human one does. So I can't recommend animal, but that is widely available. And I will say in many countries, especially in South America, they have been using veterinary grade ivermectin.
You said during your testimony that you are not a politician, you are a physician, but what are your thoughts now that you're getting all this national attention after your testimony?
In terms of politics?
Everything, just the attention that you're getting. You're hearing from your people, people are knowing your name now.
I have to be clear, I just walked out of my of the hearing and my testimony, so I am not sure what's going on in the world. All I know is that for 3 weeks, my team, my group, my colleagues, we have discovered the cure for COVID. And so there's nothing new that's happening right now that wasn't changed already. Dr. Marek is the first one who brought our attention to it. He put a video on his YouTube website weeks ago, months ago, and all I've done is work very closely with him at amassing the data. Our manuscript needs to be reviewed by the NIH, and they need to formulate treatment recommendations now.
Now, that is exactly what you asked for the NIH to review your data. And then what? Does it go to FDA? Who does it go to after that?
You don't need the FDA to approve it. I think they just need to provide guidance. If you go to the NIH website on treatment recommendations for COVID, they recommend against hydroxychloroquine. They recommend for remdesivir, which departs from the WHO, which removed their recommendation remdesivir. Their recommendation for ivermectin, which is from August 27th, currently states on the website today, it says, we recommend against the use of ivermectin outside of clinical trials. That recommendation was based on expert opinion only in August. In August, we did not have the trials data that I presented today. A lot has changed. The last 3 months, massive amounts of clinical data has come out. Not all of it has gone through peer review and publications, but it's available. The NIH has the resources to verify and validate with all those study investigators their data. And that's all we're asking to do. We're not saying we found the cure for COVID. We've identified the data. We want them to review and validate it.
Doctor, where did we go from here? Do you think that your requests are going to be answered?
I think my job is done. We need the FDA to review and validate the data and provide guidance. I do not have that authority. The country will not listen to me, even though I'm part of 5 of the smartest guys in the pandemic. Literally, my colleagues are some of the most highly published and well-regarded physicians in our specialty. And although I think we have answers that other people don't, no one listens to us. We need the NIH, the CDC, and the FDA to step in, and even the WHO. I just want to mention, a lot of our data in my manuscript, which is available for review by all of those agencies, also includes epidemiologic analyses by 2 analysts that we work with. And one in particular, Juan Chimie, he has been doing epidemiologic analyses since early on in the pandemic, showing in region after region after region that does widespread distribution of ivermectin, case counts and death rates plummet. We have numerous examples of that. We know that this is effective.
There were 3 groups of people that you mentioned are being impacted the most and are dying from COVID-19. I think you said African Americans, Hispanics, Latinos, and the elderly. Is that right?
Absolutely. We know, and I don't know if this is the right term, but you know, our units are full of those who are Black and brown and the old. It's just our Hispanic brothers, and our African American and our elderly patients, they are being decimated by this. There's just countless death. Our ICUs are full of them, and their families are getting destroyed. I mean, we have a solution. It needs to be reviewed, validated, and we need guidance.
If you could ask anything of the general public right now, especially ahead of the holidays, everyone's wanting to gather, what would you ask them or tell them?
We need guidance to implore our governmental healthcare agents and leaders who we've depended on throughout this pandemic to do your job. To do your job, review these data, listen to our advice. We are a group of experts. We have formed, our entire group has done nothing but research on repurposed drugs. We know the drugs that we know the drugs that we learn, and we're experts at all of them. This is our recommendation. We need them to hear us out. And so we need to implore our government and leaders to revise their recommendation. It's 3 months old, over 3 months old. They need to update it now.
All right, Dr. Corey, thank you so much for
This morning, the U.S. set a new record, more than 93,000 Americans hospitalized with coronavirus. It's the frontline workers who deal with the reality of this pandemic. Millions of people have now seen this photo, capturing a doctor comforting an elderly patient on Thanksgiving Day. Joining us now is that doctor, Dr. Joseph Varone. He's the chief of staff at the United Memorial Medical Center in Houston. Dr. Varone, as always, thank you so much for being with us. Thank you for your compassion. The photographer who took that picture was Go Nakamura of Getty Images, we should say. You were the doctor. Tell us what's going on there.
Yeah, what's going on is, as you know, I have been very transparent with the media. So I usually have media in our unit so people can see what's going on. So I have the photographer following me. And as I'm going inside my COVID unit, I see that this elderly patient is out of his bed and trying to get out of the room, and he's crying. So I get close to him and I tell him, why are you crying? And the man says, I want to be with my wife. So, I just grab him, I hold him. I did not know that I was being photographed at the time. And, he was just crying, and eventually he felt better and he stopped crying.
I want to be with my wife, he said. Of course. Can he be with his wife right now? Who can he see?
At the present time, he can't. We need to complete his treatment. He needs to be negative on his swabs so that we can then send him out of the hospital. But it's very difficult. You can imagine you are inside a room where people come in spacesuits, and you have no communication with anybody else other by phone if you're lucky. I mean, it's very difficult. And when you are an elderly individual, it's even more difficult because you feel that you are alone. You feel isolated.
You just mentioned spacesuit. I mean, that is what is so notable in that photograph.
Good morning, everybody. I am Dr. Joseph Varone. I'm the Chief of Staff and Chairman of the Board at United Memorial Medical Center. I want to welcome all of you, both the people that are here present, as well as those people that are following us on social media and live streaming in other measures. Today, I'm surrounded by two excellent clinicians that are here to help me explain to you what is so important to call in a press conference on December the 4th. And let me tell you how this all starts. First of all, you should be aware that we have absolutely no conflicts of interest on what we're going to be discussing. We have no shares, we belong to any speakers bureau or anything related to the medications that we're going to be talking about. What we are is we are a group. We are an alliance. In March, when we saw that COVID was killing people, we formed a group of doctors, 5 of us, which initially started to talk as to what do you do, how can we do things better, and we created an alliance. We created an alliance with people, and very humble, but people that have written among all of us more than 2,000 peer-reviewed papers. People that are usually sought for consultations by other doctors, by people asking us to be experts on a variety of different things. Most of the people that are part of our group have been well known for their things related to research, academia, but most importantly, all of us were caring for patients that have COVID, critically ill COVID patients, patients that are dying, patients that are getting into our unit. So we created a non-profit organization. And again, our primary mission was to develop effective COVID treatment as well as prevention of COVID. And the reason was because we wanted to improve patient outcomes. Our patients were dropping dead. We were getting extremely concerned. So one of the things that we did is we created the Math Plus protocol. And we actually were one of the first ones to show that this illness was extremely steroid sensitive. That means cortisone sensitive. And initially people looked at us like, what's wrong with you guys? I mean, you're going to give steroids to somebody that has an active infection. But then we proved that we were improving outcomes. In this hospital at United Memorial Medical Center, our mortality rate since we implemented Math Plus protocol has been less than 5%. I mean, that's a huge improvement as compared to the rest of the country. So we create that protocol, but then we realized that people were dying. And that's why we're here today. Today, December the 4th, we're calling people to action. It is a time of national and a global health crisis. Just yesterday, those of you know it, those of you members of the press, more than 210,000 new cases of COVID in the United States, more than 3,000 deaths. Just to put that in context, cardiac conditions, heart-related conditions kill about 500 people a day. COVID killed 6 times more people yesterday. So we have to do something about it. And I know that the vaccines are coming. I know that those vaccines are required and we need to have them all. But let's be real here. It's going to take some time to get everybody vaccinated, to convince people to get vaccinated. Therefore, we need to come up with a different approach. We need to come up with a secondary approach. We need to come up with an alternative approach that's going to help us. So today, my colleagues are going to be talking to you about this tiny little pill. This tiny little pill that we can use for treatment and for prevention. Fairly straightforward, in addition to some of the things that we do. With that in mind, I am going to go ahead and get started, and I'm going to introduce Dr. Paul Marik. Dr. Paul Marik has been a friend of mine for more than 30 years. We have written together, gosh, I can't count how many papers we've written together. He is a professor of medicine in Norfolk, Virginia. He is extremely well known for his work in the area of infections, specifically overwhelming infections such as sepsis. And I see him as a master of science. And for that reason, when we started working together and we decided that we were going to talk about this, we said, hey, who can come to Houston? And Dr. Marik will be talking to us about the eye mask protocol. Dr. Marik.
Thank you, Dr. Varone, for that introduction. So what I'm going to be talking today is I'm going to be talking about COVID-19, the spectrum of disease. I'm going to focus on prevention and early treatment, which we think is key to controlling this pandemic. What we want to do is limit people being admitted to hospital. We have all seen what a terrible disease this is. Please do not underestimate this disease. Patients are being hospitalized. They suffocate. They suffer a prolonged course in hospital, and then they die. Those who recover have significant ongoing problems. We know about the long haulers or post-COVID syndrome. There's something we need to do about that right now. So we're going to talk about pre-exposure prophylaxis. So this is prevention in treatment in people who are at high risk of getting COVID. This includes healthcare workers and people in long-term care facilities who are at a high risk of getting COVID. And what you do is you treat these people preventatively. We're then going to talk about post-exposure prophylaxis. So these are folks who are being exposed to a patient who has had COVID. The most common scenario is a family member. We know that if someone in the family has COVID, half the other members in the family will get COVID. And we know how many couples, husbands and wives, die from COVID from getting it from each other. Then we're going to talk about early treatment, and we think this is the key, that patients who get COVID need to be treated early at home. What is the point of waiting at home until you get overwhelming lung disease and you cannot breathe and are then admitted to hospital? That makes no sense. We want to treat these people early, at home, to prevent them progressing to the late phase. Now, while we have the MATH protocol, which has had an impact on the hospital treatment, patients are still suffering and patients are still dying. So we have to put our emphasis on the prevention and early treatment of this disease. And we believe we have a solution. This solution is the iMask Plus protocol. This is for the prevention and early treatment of COVID-19. The prevention or prophylaxis protocol is based on ivermectin, which is, as we'll see, a remarkable antiviral agent. In addition, we add some therapeutic agents which increase the host's immune system so that he can fight off infection. We then move to the early outpatient protocol, and it's essential that treatment be started in early. Once the diagnosis is suspected or confirmed, patients should be treated early with the goal of preventing progression to the stage where patients have to be hospitalized. And again, for the early outpatient protocol, we suggest the use of ivermectin, again, together with some other therapeutic agents, again, to improve the host's immune response. However, we must not be remiss. It's very important to wear masks. Public health measures are critical in controlling this pandemic. So when you're indoors amongst people who are not your close household contacts, please wear a mask. We know COVID is spread by droplets and aerosol. Masks protect the wearer. Masks protect the wearer, as well as those in close contact with the person wearing a mask. Masks are a critical component in controlling this pandemic. And of course, social distancing and avoiding large gatherings. We're now going to talk about this remarkable drug, ivermectin. Ivermectin. This is a 40-year-old anti-parasitic drug. It was awarded, the discovery of ivermectin was awarded the Nobel Prize in 2015. Ivermectin is on the World Health Organization, the WHO's list of essential medications. This drug is FDA approved for the use of parasitic infections. Ivermectin has been safely used in 3.7 billion, that's with a B, 3.7 billion people across the world have been treated with ivermectin for parasitic diseases. And what we know, this is a remarkably safe drug. Just to reemphasize, this is a safe drug that is exceedingly cheap. What is truly remarkable, this was a gift to us. Ivermectin has high activity against COVID-19. Let me repeat that. Ivermectin remarkably has high activity against COVID-19. And as we will see, it is highly efficacious for pre-exposure treatment, for post-exposure treatment, for treatment in the early symptomatic phase, and remarkably, it has clinical activity in the late stage in hospitalized patients. There is now new and compelling data that has emerged in the last few months. And this is important because it was in August that the National Institutes of Health reviewed the data, and their recommendations are now out of date. And that is one of the reasons we are meeting here today.
Thank you very much, Dr. Marek. Excellent. It's amazing how a tiny little pill like this, can make a difference. And we will review now the amazing data. So again, let me just reemphasize again, we have no conflict of interest with regards to this medication. We're not part of any studies or anything that has to do, or they pay us money to talk about this. Like Dr. Marek says, this was a gift to us. It just came out of the blue after we started reviewing the data. And we're extremely impressed with its effect. Indeed, at United Memorial Medical Center, every patient that gets admitted goes on ivermectin, every single patient. And our outcomes are some of the best outcomes in the nation. To discuss a little bit about the studies and actually the data that some of you may be interested in, Dr. Pierre Corey, who is an associate professor in Wisconsin, will be explaining to us briefly some of these studies. All of these studies are part of your press kit. Please, if you need anything, go to the flccc.net website. We have there everything you want to know about the IMAX protocol, everything you want to know about the Math Plus protocol. Dr. Corey, please.
Thank you, Dr. Varone, for the introduction. I want to summarize this really incredible and very compelling emerging data. Before I do that, I want to be clear. This press conference is about a call to action. We are asking our healthcare authorities to review these data and provide us more specific guidance. While we wait for that, I'm asking every healthcare provider in the country, the doctors, the nurse practitioners, the physician assistants, to please review our manuscript in which we've compiled all of this data. It is extremely compelling, and you need to educate yourselves because we believe you can truly help patients. There are 100,000 patients in the hospital today in the United States. We need to stop filling the hospitals. Now, we have growing numbers of studies. Since the manuscript was completed days ago, it is already out of date. There are studies coming out last night, the day before. There are at least 35 studies. All studies show positive benefits. The majority show decreases in mortality, decreases in hospitalization. The most important aspect of this data, and just recently in a major medical US journal, a study done in Broward County by Dr. Ratcher, again, showed the same thing, decreases in mortality, especially amongst the most severely ill. This drug saves lives. The other thing that it does, and this is, again, as my colleagues mentioned, how this has been a gift in this pandemic, is its efficacy as a prophylactic prevention agent. We now have 4 large trials, including over 1,100 patients, 3 of them well-designed randomized controlled trials. And I want to go through them because I think they're extremely important that everyone understands how to protect themselves from this illness. The first one done in Egypt, over 300 patients. They took patients who were positive for COVID-19. They identified all of their household members. And in over 200 of those household members, they told them to take ivermectin. In the other group of COVID-19 patients, they did not give the household members ivermectin. And as you can see on this slide, 7% of those who took ivermectin contracted COVID-19 compared to almost 60% of those that didn't prophylax with ivermectin. You could see that with ivermectin, it absolutely protected almost perfectly most of the household members. Be clear that many of those household members probably were already exposed when they took ivermectin. Similarly, in India, in the Old India Institute of Medical Sciences, many of the physicians on the front lines with high-risk exposures, some of them started taking prophylaxis. In those healthcare providers that took ivermectin prophylaxis, only 16% got sick, while their colleagues who did not take it, 60% got the disease. Another study just came out last week, again, a randomized controlled trial done in Iran, where they prophylaxed, again, household and healthcare contacts of those with COVID-19, only 2% got sick if they took ivermectin, compared to the 10% that did not. The most encouraging is this study, where they gave prophylaxis to healthy citizens in the population. They were not exposed. They were told to take ivermectin for a month. At the end of that month, nobody on ivermectin got this disease, compared to 11% of those healthy citizens that did not. This is an effective therapy. We all know this study just came out in a French journal, and this is extremely important. We know about how this pandemic has hit some of our long-term care facilities and nursing homes the hardest. We have had many of our elderly citizens die. In this nursing home, it's almost a fortuitous or lucky circumstance, but what happened was in one nursing home in France, there was a scabies outbreak. Ivermectin is very effective against scabies. All of the patients or the people living in that facility were on ivermectin at the time that one of the residents got sick. They were completely protected from the spread. Nobody in that facility got this illness. In local other homes where they were not on ivermectin, 22% of the residents got this disease. And if you know anything about this disease, the older you are, the more frequently you die. That saved lives in that nursing home. And so we also have now evidence that we can protect some of our most vulnerable citizens in society. Now that's just the prophylactic data. Again, you can review our manuscript where we've compiled everything. But like Dr. Marek said about these phases of disease, I've reviewed the prophylactic data, the preventive. We now have lots of data on early treatment. So outpatients, we have randomized controls and large case series. They all show dramatic reductions in the need for hospitalization and dramatic reductions in mortality. In the Dominican Republic, a group there in their protocol used ivermectin. They reported on 2,700 patients that they consecutively treated with ivermectin. They only saw one death and only 16 patients needed the hospital. Again, we have 100,000 patients in the hospital today. And if everyone was on ivermectin, I can guarantee you that would be far, far less. And then almost incredibly, a drug that has antiviral activity is working late phase in the hospital, where really the disease is one of inflammation. The virus is not replicating or attacking us at that point. It's our bodies responding to that virus. And it's even working then. It has incredibly potent anti-inflammatory properties. We have almost 3,000 patients in 8 trials, 4 of them randomized and large, all showing statistically significant reductions in mortality. Lives are being saved with this medicine in the hospital. Again, this slide, which summarizes the data, is out of date. There's more and more studies coming. They're all consistently positive. Now, the most dramatic, and I think the message to the world, is that this is already altering the pandemic in many regions of the world. We have 2 analysts that have joined our alliance that have worked with us, and they've provided us this data. One is Juan Chemie, and the other one is Alan Cannell. And they have been looking at all the world's databases and looking at case counts and case fatality rates. There are many regions of the world in which ivermectin has been used widely. One of the most dramatic examples is what happened in Peru. This slide focuses only on those patients over 60. It's not confounded by the rise in young patients with infections. But when you look at patients over 60 in those 8 states, to the left of each graph is a shaded area. That was the time before ivermectin was widely distributed. And if you see in each of those states at different time points, just at the moment when they started to widely distribute ivermectin, the case fatalities peaked and began to fall, approaching near pandemic levels. They controlled this pandemic in those regions in Peru. This is also seen in this slide, where the case fatality rates in patients over 60 plummeted. Before ivermectin was used widely, you had a 30 to 60% chance of dying if you were over the age of 60 years old. And after ivermectin was widely used, less than 10% of those elderly patients were dying. This slide shows what happened in Peru compared to Lima. If you look, the red bars in the background, The 8 states are in the blue lines. If you look at the red bars, in Lima, they did not distribute ivermectin. It was not used in the largest city in Peru. And you see astronomically high deaths and case counts, which did not decrease in line with the other regions in Peru that did it. We have numerous examples. You can go to our website. Our analysts have compiled many, many examples from many, many regions. I'm only going over some of the most dramatic ones. But here again, you could see it in Mexico, in the state of Chiapas, in southern Mexico. After August 1st, when they started using ivermectin, the case fatality rates per 100,000 dropped. It's the lowest in Mexico and even amongst the world, 4 per 100,000, whereas beforehand it was 28. So dramatic reductions. And the last one I'm going to tell you is that one area, Alto Paraná in Paraguay, the governor got COVID, him and his brother, and they took ivermectin. They got better and they became convinced that it worked. And so they started a distribution campaign. A month and a half later, they reported that there were no COVID cases in the hospital. You could see the plummeting deaths and case counts. They have controlled COVID in that region with the use of ivermectin. Thank you.
It is amazing how this tiny little pill that I've been talking about can do all of those things. I mean, I guess that many of you would say, just give me one, give me a pill so I can take it. But it's real. And like I said, I have seen it in the hospital. I have taken this medication. So has Dr. Corey. So has Dr. Marek. I mean, we had to try it, to be honest with you. We had to try it because I know it sounds too good to be true, but the data is there. And that's why we felt compelled to call for action. We call for everybody to discuss these things. And I'm going to ask Dr. Marek to just briefly explain to you why we are so passionate about this. Why do we believe this is a game changer in the pandemic? We want to make a difference. Dr. Marek, can you talk to us?
Thank you, Dr. Varone. So all three of us are intensive care specialists. We are ICU specialists. We work at the bedside every day. And for the last 9 months, we have been witnessing this terrible disease, which has taken over 200,000 lives in this country and over 1 million worldwide. And it looks like things are now completely out of control. We now need a national and international and global call to action. We are calling the national and global health authorities. Please look at the data. Please look at the data. This data is now widely available. We have to act now. We have to act quickly. We have to act with compassion. We have to do what we can to end this pandemic. By slowing and ending this pandemic, we will then allow the businesses to open up. We'll allow schools to open up. We will allow the economies across the world to open up. We can't sit by idly and no longer do nothing. While we know that vaccination will make a difference, we are still many months away, and we believe we have a bridge until we reach that point. This table reviews the results of the failed and successful treatments of COVID-19 by phases of the illness. This is a very important table. It's broken down into pre and post-exposure prophylaxis, the early symptomatic phase, and the hospital phase. You can see all those medications which have been tested in randomized controlled trials and the various phases of this disease. In green, which means go, are the only drugs which have been shown reliably, reproducibly, consistently to show benefit. And let me point you to the direction. Corticosteroids for the hospital phase of the disease. Ivermectin. Remarkably, ivermectin has been shown, as Dr. Corey has presented the data, to be beneficial in pre and post-exposure prophylaxis for the symptomatic phase of the disease and for the hospital phase. This is a cheap drug. This is safe. We should be able to act now to control this pandemic. We appeal to the national, international, and global health authorities to please review the data. This is a crisis situation. We have put together a document which summarizes all the information on ivermectin. This is available on our website, as well as other helpful data. We implore doctors, physicians, healthcare providers, nurses, physician assistants, please familiarize yourself with this information. It's up to you to help us collectively save the world. We have to do this now. People are dying. We are appealing to these national and global health authorities. Please review the data and provide guidance to healthcare workers across the world so that they can prescribe this medication. As of this morning, over 2,000 people have died in this country. These people suffer a miserable death. They suffocate. We can no longer stand by idly and do nothing. We have to act. We have to act now. We have to act with conviction. We have to act with compassion. It's now time. Thank you.
Dr. Marik's words are echoed by everybody at the FLCCC Alliance. We all have been working very hard. I've been working 260 continuous days without a single day off. We're doing this also because of us. We are tired. We're exhausted. We're helping these patients that are dying in front of our eyes. My nurses cry in the middle of the day when they see their patients dying. We need to do something. We believe that the IMASK protocol will change the face of this disease worldwide, and that's why you guys are here today. That's why we have you here. You are our voice. You are the only way by which we can transmit this information out there, and we urge you to listen. With that, I will ask you for any questions that you may have.
Thanks for the great presentation, docs. What is the dose and how much does it cost?
Thank you for that good question. So it's actually very simple. So we make this simple so it's not complicated. For an average 70 kilogram person, the dose is 12 milligrams. So it's 150 to 200 micrograms per kilogram, which works out at about 12 milligrams. The tablets come in 3 and 6 milligram tablets. So what you want to do is take 12 milligrams. It's done twice, day 1, day 3. It's very simple. It's not complicated. 12 milligrams, day 1, day 3. And then for prophylaxis, for long term, it's then once a month. This is my box of ivermectin. This cost me $10. Okay, so it's a really good question. It's very simple regimen. It's not complicated. The average dose is 12 milligrams, repeated twice. Thank you.
Is this still available for prescriptions right now?
Yes, so you do need a prescription from your physician. So we recommend, that's why we're here today. We're trying to inform the healthcare authorities. We're trying to inform physicians so that patients can go to their doctors and get a prescription for ivermectin.
Hi, I'm a physician in the community, and I found an easy way to do the calculation is it's the weight in pounds divided by 11. So it makes it very straightforward. Your original protocol was for ivermectin weekly, and now it's the 1-3 monthly. For those that are already on a weekly regimen, do you suggest that be changed?
Yeah, so I mean that's a good question. So what we know about ivermectin is that it has a really long half-life. particularly in the tissues. So it gets into the tissues. The concentration in the lung is at least twice that in the serum. So it has a long penetrance and long persistence in the tissues. So that's why we think once monthly is probably the most cost efficient and economic way to do it. We know that you all give heartworm to your dogs. Heartworm is ivermectin. You give it once a month. It is a remarkable drug that has this long persistence. So we think to improve compliance, giving it once monthly is probably as good as once weekly. Obviously, we don't have really good comparative studies, but I think it's probably the optimal balance of once a month.
Thank you.
The side effects. So the question was side effects. So as I said, 3.7 billion, that's with a B, billion people have been treated with ivermectin. The most common side effects in people treated are related to the death of the parasite rather than the medication. So patients will have itching, some degree of skin rash, but we think it's because of the death of the parasite rather than the medication. So this is a remarkably safe drug. Remarkably safe drug.
Doctors, the next question comes off of the live stream. The question is, are you at all concerned that given the investment of billions of dollars into the development of a vaccine, that federal agencies will be less inclined to consider authorizing the use of ivermectin?
The fact is, as we said, we are not trying to take over vaccination. On the contrary, vaccination is extremely important. But let's be realistic. There is no way you're going to be able to vaccinate 60% of the global population, which is what you need in order to have some degree of immunity, anytime soon. I can tell you, my own colleagues are saying they're not going to get the vaccine. My own friends, the Latinx community, the African American community is very resistant and reluctant to get the vaccine. So we got to do something else. We're not going to fight with the vaccination program. We want to work with the vaccination program hand by hand. Other questions?
Yes, doctors. Another question from the online, from the streaming. As many doctors have fought me on this, this is the question from the person asking, what is the downside to giving prophylactically or in late stage? I myself took late stage and it took away every residual symptom.
We've discussed this amongst ourselves. I've been prescribing it already. It's already part of my standard practice in the treatment. I cannot identify a downside. As Dr. Marek went over, this has one of the longest and unparalleled safety profiles of any medicine. It won the Nobel Prize. It is an essential medicine in the world, and it got that way because of its safety and its efficacy. It is cheap, it is available, and it is profoundly effective against this disease. I cannot identify a downside at any stage in the illness.
Thank you. Another question from the live stream, doctors. What politicians and government officials have you contacted that have agreed to work with you? And have you been ignored with this message?
Our protocols, and so iMask is our second protocol. As critical care ICU doctors, our first focus was on treating those severely ill. Our protocol, which was Math Plus, reached many levels of the government, the Department of Defense, the White House, the task force. We know that through our contacts and our colleagues, they have seen our protocol. We did not get any specific response for them on the Math Plus protocol. The iMask Plus has also gotten to numerous members and healthcare leaders in government. We still have not gotten a response. This is another reason why we are calling a press conference. We cannot seem to get our message heard in any other way.
Thank you, doctors. Another question from the live stream. Should patients be prescribed ivermectin in outpatient setting post-COVID if they're still requiring oxygen?
The fact is that patients with COVID, remember, first thing is that the immunity that is conferred by COVID doesn't stay with you. You can get COVID again. So yes, these patients you can redose these patients or dose these patients with with ivermectin. There is no question about that. Everything really depends on the staging that we are talking about. Just like Dr. Marek explained, this is a drug that works in the pre-exposure, during the early phases of COVID, and during the late phases of COVID. So I don't think there is any downside in doing that, because there is still going to be, remember, the way by which ivermectin works, it does it by two mechanisms. Mechanism number one is an antiviral. So when you have that replication phase, it's going to work. But more importantly, it's an anti-inflammatory agent. And we know that COVID kills you by two mechanisms. Mechanism number one, inflammation. Mechanism number two, excessive clotting. So we know that we can use it in that setting.
Yeah, I just like to make 2 points. The first about vaccination. I don't think this is a competition. I think this is a bridge. This is a bridge to vaccination. People are dying today. People are dying today. More people will die tomorrow. Vaccination are not going to save these people. The ivermectin and vaccination are complementary. They're not competing with one another. We have to do everything we can to get this pandemic under control so we can open up this country, we can open up the world, and we can develop some kind of normal life. Regarding the post-COVID syndrome, this is a terrible syndrome. At least 50% of patients who have COVID suffer from headaches, tiredness, fatigue, palpitations, and this goes on for months. We believe that this is due to unresolving inflammation. We have had anecdotal reports of patients who've taken ivermectin for the post-COVID syndrome and have reported excellent results. There is, in fact, a publication in the peer-reviewed literature in which they did this exactly. They treated the post-COVID syndrome with ivermectin and reported a 90% improvement in patients. So it is a remarkable drug which we think can help us, together with all the other measures, turn this terrible pandemic around.
Thank you, doctors. Again, off of the live stream, this is a question regarding steroids. So in your Math Plus protocol, using steroids, now if we're going to also use ivermectin, the question is, does that block the antiviral actions of ivermectin or other components of IMASC?
No, our protocols from the beginning have been essentially combination therapies. They work synergistically or together. They're all complementary to each other. Ivermectin does not remove the critical need for steroids. In fact, steroids is the mainstay of the therapeutics. It always has been and always will be. We just believe that, we have the data showing that it has an additive role. Many of those studies were done in patients getting steroids, so that you still need to stick to all the multiple components of our protocols. They're critical.
Thank you. Another question from the live stream. What are the contraindictions of giving ivermectin?
So there are essentially none. The only thing that you have to worry about with ivermectin is what we call drug interactions. There are a number of drugs, and if you go to our paper, we list where you can look up the drugs. And the interactions do only one of two things. It either lowers or it increases the serum levels of ivermectin. So you need to be cautious. If it's a drug that lowers the ivermectin levels, then you might want to do a higher dose, but you should consult with your physician on that.
Thank you, doctors. So go ahead.
Sorry, just to expand on that, there is one drug interaction to be aware of, and this obviously is a very narrow group of patients, but patients who are on cyclosporin, so these are immunosuppressive drugs, so patients who have kidney or liver transplant taking tacrolimus or cyclosporin, there is a specific interaction between ivermectin. So what that means is these patients need to have their drug levels monitored closely. So that's why your physician has to be involved in this decision. The physicians have to understand this drug. And as Dr. Corey said, this drug is remarkably safe. The only problem are drug-drug interactions, and the group that is most important are the drugs used for transplant rejection.
Thank you, doctors. Another question from the live stream. My fear is that the academic physicians will call for randomized controlled trials. Do you feel that what we see, for example, in the French nursing home observation and the public health measures should forego more randomized trials?
I mean, actually, we both are going to answer that because we're both passionate about this. Let's be clear. This is a time of war. You don't have time to do control randomized trials. Just like Dr. Marek very explicitly said, and very emotionally said it, people are dying. You don't have time to wait 6 months for a randomized control trial to be done. We gotta act now. And that's what we do. You try something, it's working. How am I gonna not give it to 50% of the patients when I know that it's working? It doesn't make sense. For me, that would be completely unethical.
So the call for randomized controlled trials is a bit puzzling to me. If you look at the data in which we present, there are numerous randomized controlled trials involving now thousands of patients. How many trials do we need? My entire career, I have been faced with doctors, and in particular in academia, where they always say that there is insufficient evidence to adopt a therapy. No one has ever defined what sufficient evidence is. The evidence, in our opinion, as experts at the bedside, is more than sufficient. There are thousands and thousands of patients. Another point that everyone must understand is this emphasis on the need for randomized controlled trials. Well-designed observational trials are sufficient. They lead to the same answers. They uncover truth. They are more ethical in a pandemic. You can give ivermectin to large groups of patients and compare them to patients that didn't get it, but you do not have to give placebo. It would be inhumane to give someone placebo given the mountain of evidence that we've just presented today.
Thank you, doctor. Another question from the live stream. You said we could open up the economy with this. Can you explain further?
If you look at the case counts and transmission rates and deaths that are being reduced in the areas of the world that are using it, they're controlling the pandemic. It will no longer become a major and active health crisis. We will not be filling our hospitals. It will be safe. The amount of virus that's traveling from host to host throughout the population will rapidly decrease. It has been shown, and that's the data that I presented, that in those regions, they are not suffering to the scale that we are now. Once it's safe and there's not virus traveling among us at these incredibly high rates and causing death in their wake, it would be safe to go back to work. It would be safe to congregate in spaces again and go back to our social activities that we're all missing, that everyone's suffering from, let alone the economic climate where people are becoming bankrupt. We're all becoming impoverished. We have a solution. We just need our authorities to listen and review these data and validate the data and provide guidance. This is a call to action.
Thank you, doctor. The next question off of the live stream fits with that. Can you clarify what is the FDA's recommendation on ivermectin for COVID-19 right now?
So as Dr. Marek pointed out in the beginning, that recommendation is dated. It is from the end of August. And at that time, they recommended that ivermectin be only used in clinical trials. I want to point out that recommendation was graded as expert opinion only. It was based on no evidence that it didn't work. There was not enough evidence to say that it did work, but a lot has changed. Like I said, just in the last 2 days since I finished the manuscript, multiple trials have come out. It is rapidly emerging. They are available on multiple medical preprint servers, and they're starting to come through peer-reviewed journals. It is time for them to convene a task force dedicated solely to looking at these data. The data of our analysts, what they did, these epidemiologic analyses, they can reach out to them. We will put them in contact with our analysts, and they can review and validate that those analyses were done correctly. They can review the sources of all that data, and they can reach, we hope, same conclusions and provide excellent and specific guidance now.
Thank you, Dr. Corey. Another question from online. How long would someone how long should they prophylaxis with ivermectin?
I don't know that we have the answers to everything, but I would say the following. If you look at some of those areas of the world where it's essentially gone back to pre-pandemic levels, the deaths and the case counts, I would say until this is over, but I think they have a path till it's over, until the case rates and the infection rates are so low that the risks are minimal. And at that point you could stop. And I hope that would be a time that would be relatively soon, maybe months, maybe a year. I don't know.
Thank you, doctor. Another question off the live stream. Do you recommend that a healthy person use ivermectin prophylactically? If so, would the same 12 milligrams monthly be the correct dosage? 12 milligrams monthly.
Yeah, first of all, again, remember the dosing is on the basis of how much you weigh. And again, we have all this data at our website, flccc.net. The question is whether or not a healthy person should take it. Well, I guess I consider myself healthy and I do take it. Now, have you been exposed? What do you do? What kind of things? There is a lot of actually good data and data that Dr. Corey just showed where no one, absolutely no one in one of the studies got COVID. So I would say yes, absolutely. Any other questions?
Yes, doctors. You have covered a lot. The questions coming from mainstream the live stream. What now? Talk to us again, because we're still facing, we can't go out and get a prescription. The data sounds good. What now? What do we do? What needs to happen in order for this to move forward and do what you're saying here at this press conference?
Beyond today's goal, which is to disseminate this information and ask for guidance from our health authorities, we do not have that authority to change anything beyond dissemination of our knowledge base. What I've been doing for weeks now, because we've all been faced with this question as the clinicians, as part of our COVID-19 Critical Care Alliance, is I implore them to take the paper, show it to their doctor or their nurse practitioner, their physician assistant, whoever their provider is, and have them review it and then make a decision. We believe that manuscript and that evidence is compelling and convincing. Beyond that, I don't know how else I can help a doctor or healthcare provider prescribe it.
So today we have a call to action, and the call to action is to national and international and global health authorities. Please, you cannot put on your blinders any longer. We need action. We need action today. We need swift and decisive action so that you can provide guidance to clinicians across the world to prescribe this medication. It's that simple. We need the help. We need the help of our national and global health authorities to help us terminate this terrible, terrible disease we're facing.
With that, I want to go ahead and conclude this press conference. We will be available for any independent questions that you guys want to ask us. I want to thank all the members of the media. I want to thank United Memorial Medical Center for everything that has done for me and for our cause, to call it a cause. And I want to remind you that we are available online at flccc.net. All the data that was presented today, the seminal paper that we've been working on now for months, it's available for you to read it, to take it to your doctor, to your healthcare provider. Thank you very much, everybody.